Welcome to Robert Wood Johnson University Hospital's Health Talk. I'm Dr. Douglas Oshinsky of Robert Wood Johnson Physician Enterprises, Warren Internal Medicine. On today's show, we focus on eating disorders. While its name implies that it is about eating, eating disorders are really not about food. They are a coping mechanism for dealing with other stresses and issues going on in a person's life, and treatment involves a multidisciplinary care. We are pleased to have with us three representatives from the Eating Disorders Program at Robert Wood Johnson University Hospital, Somerset, to tell us more about the disease and its treatment. I want to welcome to the show Jean Beaucham, who is a registered nurse, Brian Pollack, a therapist with the program, and Christine DeSouza, head dietitian for the program. Thank you all for being here. First, let's define to our audience what an eating disorder is and what the types of eating disorders there are. Each one of you can give us a little description, or if you want to expand on what the other says, please do it.
Great. Well, thank you for having us here. We're excited to talk about the Eating Disorders Program at Robert Wood Johnson. Eating disorders are often, can be seen in different lights. There's things that people do around eating that often can compromise their ability to maintain stability. Sometimes you'll see disordered eating in the fact of people eating odd objects or even binge eating, but what we really focus in on over at Robert Wood Johnson is the symptoms of anorexia and bulimia nervosa. Anorexia mainly is a restrictive disorder where a patient or a person has difficulty keeping above 85% of an ideal body weight, which is set by government standards. And they have a fear that if they do go above that 85%, they will be either unhappy, affected by the world around them, or even fat is a word we often hear. They also have a lot of difficulty with the shape of their body. Person might feel as though that they're not comfortable with themselves, and there is an obsession around maintaining weight in order to find happiness. And also there is recently it's been changed in some of the diagnostic material, but for women particularly, stopping the cycle for 3 months to not be able to have that experience, unfortunately, is a sign of restrictive anorexia. Bulimia nervosa is seen as somebody who cannot maintain control over their eating. They will incessantly take too much in within a specific time period. An example would be 2 hours. Let's say someone eats way too much above what a regular or normal person would. They also do have the body distortions, like in anorexia nervosa, and there's also the fear of getting fat. Sometimes with bulimia, you'll see what we call purging, which can be seen as somebody who induces vomiting on a regular basis after their meals, or also somebody who uses laxatives or excessive exercise.
So the two large categories in eating disorder are anorexia and bulimia. Those are the two large categories that are treated at the Eating Disorder Center. Jean, tell us a little bit about, as a registered nurse, what it is to deal with these people.
Well, on our unit, we have a variety of ages and different backgrounds. I think that's the surprising thing.
Such as what age to what age?
From age 14 to 72, we've had patients. I think there's a common misconception that people with eating disorders are teenagers, college-age women, and that doesn't seem to be the case. We do know that approximately 1 in 7 to 1 in 10 patients are male. And we also know that it goes largely unreported and largely untreated, so that their estimates up to 90% of people with eating disorders aren't even in treatment. So for our experience, it's, from the nursing perspective, we look at a wide variety of patients and we try to accommodate their needs in getting back on track with their eating.
And from the dietitian point of view?
Where to start?
Start from the beginning.
It's really difficult because when a patient comes in, we need to figure what's eating disorder thinking and eating and versus, you know, preferences or if they tell us they have allergies or you know, other medical issues going on. So we really need to get a thorough history and, you know, just learn about their specific eating disorder because every patient is different. There's no two patients that have the same like meal pattern or nutritional pattern, and yeah, it's just.
And then from your point of view as a therapist?
Well, it's, again, varied. There's so much that goes on, but when you talk about what we were mentioning about the restrictive and some of the induced behaviors, you're also seeing a lack of social inclusion. People like to isolate. You'll find in the family there's a big, often rift that goes on, misunderstandings between parents and child or adult. It can be wife and husband, etc. Relationships really do kind of go into turmoil. There's just, often we'll also see co-occurring disorders, things such as depression. Somebody also may be possibly bipolar. There's, you know, it's very complicated at times, so we're often treating the eating disorder, and then we're also helping if there is an underlying situation going on as well to help manage and cope through all of this.
So how do these people suffer? How does it develop? And how do they eventually get sent, you know, from my office over to you?
I think the first thing is that if there seems to be a lot of irritability and a family member notices that there's some disordered eating going on, go to either your pediatrician or your general practitioner, talk to them.
We also see, actually, if I can interject, a lot of times school nurses will pick up at the beginning of the school year patients that have lost a lot of weight through the summer or they have a concern there. And family members often will call the unit trying to find out what do I do with this patient? You know, what's going, you know, I don't know what's going on with my son or daughter, and we can direct their call to, you know.
So the people out there, what are the signs that they should be looking for as warnings that something that they may be developing an eating disorder and that we should step in, or they should have that person seen by their physician, or if they get a call from the school nurse saying such and such is happening, what are those signs, the warning signs that we should be looking for?
Well, the first things that we usually encounter are obviously weight loss from the restricting behavior. Very often family members will report the patient will eat and then immediately go to the bathroom. So they're suspecting that they would be vomiting or, you know, the self-induced vomiting, purging, or they go out and run an excessive amount to try and get rid of those calories. There's other symptoms too, I'm sure.
Yeah, we often, you know, like I said, the excessive exercising, some students or even adults, they'll go out and they'll run 15 miles. But you also have people who, you know, they have trouble even just relating. They have trouble being able to find a stable environment for themselves. They seem to always either be in a mode where they're extremely upset and irritable, or they just cannot seem to grasp a sense of how to participate with the individuals and attachments in their lives.
So what you're describing is not only is it really a eating disorder, but they may have some other type of medical illness, such as anxiety, depression, not feeling good about themselves, and that may be what triggers the eating disorder.
100%. And you know, one thing that maybe we haven't covered is on the medical side, as you just mentioned, low blood pressure, right?
We do see orthostatic changes.
Dehydration.
We do see dehydration and malnutrition. We do, with patients with long-term eating disorders, can develop kidney problems, heart problems. Certainly the vomiting can cause blood dyscrasias, blood problems, electrolyte changes that can cause cardiac problems too. So that's, over time, it can be very harmful.
So I've got this patient who comes in to see me in my office. I'm an internist. She's 18 years old. She came in a year ago with a physical. She's dropped 12 pounds. She's, you know, even though she went to her first year at college and normally should have gained 15 pounds, actually lost weight. What as a primary care physician, should I do? What should I be alerted to? And what should my actions be to try to get this person into the multidisciplinary approach that you guys do?
Wow.
That's a tough
Good
question. There's definitely signs to be aware of. You know, just backing up a little bit, when patients come in, they usually tell me that, a doctor told me that I needed, to drop weight or lose weight. So it's very important what the physician says to the patient and how they approach the patient in addressing any issues that are going on. But certainly, the issues that Brian and Jean spoke about, like the low blood pressure and just the complaints of dizziness, fatigue, poor nutrition affects every aspect of the body. So, a patient may be pale and just, just eyes sucking in and dry, brittle hair that comes out. And so what you could do is, definitely have a referral source, I would say, and bring up your concerns with the person, or even with the parent, if a parent is there, if it's an underage person. Sometimes they're not aware of anything going on, or sometimes they may be aware, but they don't want help. But I think that, if you could call attention to like some things that you're concerned about, and what could happen, then that could raise some awareness in them, right?
Definitely. A couple of other things maybe, as you were saying, I was thinking maybe the physician or the internist can ask how the person feels about their body. If the internist mentions their weight and they notice that the individual seems to have a strong reaction to the number that was presented to them, that might be a sign. If the person reports that they are going under amenorrhea, which is the halting of the natural cycle for a female, that can be part of it. There's definitely signs with what you're talking about, the brittleness, the loss of color. You'll notice that the person possibly is withdrawn. Their affect could be quite detached. You'll also see that there might be an obsession over a particular item that's being discussed in the doctor's office. If it has to do with food and the patient's asking a lot about, what kind of calories should I be eating, and what is this food okay, et cetera, which might seem more appropriate for a nutritionist or someone of that nature.
So I've got a college student in my office,
Yep.
and the parent says that their grades haven't been kept up as well as they'd like.
Sure.
Something I should look into possibly?
We do see that often because the concentration is affected with poor nutrition, and certainly the restricting behavior would contribute to that. Very often they do have problems with the schoolwork. I think also the doctor would probably want to check blood work and an EKG, because we often see bradycardia, we often see the heart rate lowering as a result of the malnutrition from restricting, or the binge purge cycle of bulimia.
In the elderly person, what do you usually see there? It's something that most of us don't even think about.
Right. Well, we do see sort of exacerbation of the symptoms. We do very frequently, our older patients have lived with the disorder for a long time. So we see osteoporosis or osteopenia. We do see sometimes changes in the kidney function as a result of the restricting behavior, and even to the point of laxative abuse that can cause kidney stones, which damage the kidneys. We've seen that in some of our patients.
In the older person who has the eating disorder that may have kept it under control, is it something that happens in their life that may suddenly trigger it off, such as a spouse passing away, or maybe they were in a job for 30 years and suddenly the job's no longer there, or something happened monetarily? Would that be a trigger?
Yes, it can be, and just like in any illness, there are things that can trigger someone throughout their life. So we often think of eating disorders as like a continuum, and so anything can set off symptoms or worsening symptoms. But very often those change of life issues do affect the eating disorder as well.
Especially if there's not a good support system.
Well, that's the problem. If a spouse
Yes.
passes away and that
There's
other
no one
spouse
else
is
to
left in the house by themselves, It's who will actually see that person and make the thought, oh, maybe they need to see someone.
Or other illnesses. You know, people who all of a sudden have a new diagnosis of a life-threatening illness, that can make the eating disorder worse too.
Now let's talk about when I do convince someone it's time to go to the multidisciplinary program over at University Hospital in Somerset. Start me from the time they come in till the time they leave, and then of course aftercare. Tell me how it works.
Okay, so we do have, it would start with the referral to our Access Center. And in our Access Center, there's an initial evaluation done by a nurse who will be able to, and then also they are called over into meet with our 2 psychiatrists. The psychiatrist is the gentleman, Dr. Donnellan or Dr. Joseph Rockford. The 2 of them are the ones who really do the evals and help to decide, and they meet with the patient, sometimes the patient's family, and there is a decision whether they should come in or not.
Now, when you mean come in, do you mean inpatient?
Inpatient treatment or the 2 levels of partial hospitalization or
Because as you
intensive.
know, Robert Wood Johnson University Hospital in Somerset is one of only 2 hospitals in the state that has an inpatient care for eating disorders. So this way they actually have the option at that point whether they feel it's necessary to be an inpatient or it can be treated as an outpatient?
Depends on the severity. I mean, if you have somebody who's coming in who's quite low, under that 85%, inpatient will be the recommended treatment. But yes, if there's somebody who does want to go to partial and our intensive outpatient program, those are options as well, depending on the severity of the difficulty. So that decision will be made and discussed with the 2 psychiatrists and doctors on the team.
And that's a voluntarily admitted inpatient?
Yes.
Yes, it is a voluntary unit. And after those evaluations, then we figure out what the plan of care is going to be for that patient.
Common inpatient time that they're in the hospital. Is there such a thing?
Well, that's a question we get a lot. And actually it depends. If the person is anorexic and they have a hospital goal weight to achieve, that may take some time. We've had patients up to 3 months, depending upon the severity of their weight loss. We've had patients coming in in the 60-pound range, and sometimes to restore them to a more normal weight, it can take some time. And then the other question would be how long for somebody who doesn't have anorexia. Sometimes bulimic patients, it can be 7 to 10 days to stabilize whatever's been going on with their eating in order to transition them back to an outpatient setting or home. So it really varies very much. It can be 7 to 10 days, 2 weeks, up to 3 months, depending upon the patient.
They're admitted now to the inpatient units. Tell me what each one of you does, what each one of your, what nursing does, what dietary does, and what the therapy does.
Well, from the nursing standpoint, the patients are weighed every day. The patients don't normally know what their weight is going to be. We tell them several times during the week, but to not obsess about that. There's time for self-care, and then the meals are monitored by nursing staff, so breakfast would be monitored. The bathrooms on a unit like this are locked for a certain period of time after the meals to prevent the purging. They're permitted to use them, but with the staff supervision, unlocked. And then lunch and dinner would be the same thing as far as the monitoring of the meals. And then we also monitor for side effects for the medications as prescribed by the doctors. We look at their vital signs because very often patients have orthostatic changes, as I mentioned, so we check that. And it's basically support throughout the day in their eating.
Dietitian, very important.
Right, well
Yes.
then Jean will call me and say, we have a new patient, can you do a menu with them? So what we'll do is we'll meet with the patient and a dietitian will conduct a nutritional assessment. And that's basically us sitting with the patient one-on-one and getting a picture of their behavior and the history of the eating disorder, their pattern of current eating, their previous pattern of dieting, and just, you know, all of the background information. And based on that, we could see like specific nutrition problems that we could help address. So, for example, you know, if a patient comes in and you know, they're in like an adolescent, let's say, and heavily into sports and they haven't gotten their menstrual cycle, and you know, they've just been, you know, maintaining this kind of pattern for a while, we would suggest, you know, okay, well, you know what, how is your calcium intake? And if they can't give me like a good recall or you know, from their background, you know, we would suggest like, okay, we need to check your bone health, you know, and just the things that I find out from them, like medical issues, I would recommend to the team, or if the patient confides in me anything that I think the rest of the team should know, like something that's out of my scope, like abuse or something that I should tell the rest of the team, especially Brian, or if I notice something in the labs that I think is important, then I would share with.
So again, the whole multidisciplinary approach, bringing it out that maybe Jean sees something, maybe you see something, maybe the therapist sees something, or someone else who happens to be here, and that may be the key to getting the person past the stump. Right. Psychology-wise?
There are 5 therapists on the team, and one of the big points in which we're all talking about is the need for communication. So what we really look at is the communication patterns and the struggle or the situation the individual's in. So when we first meet with them, we do what we call social history, and we get to know them, their belief systems, how the patterns of the eating disorder have been going over the past 6 to 12 months, and then also when did they initiate? Was it this year? Was it 10 years ago? Was it 30 years ago, depending? We get a history of their family. Do they use substances? What has really influenced their experience? We do this to, and unbiasedly, without any judgment, to offer empathy and support. And after they do that, which is within the first day, on the inpatient unit, they're in groups all day. Every group is run by a therapist, a nutritionist, or a nurse, and sometimes we'll have part of or all of the team go in and help and assist.
Again, the whole multidisciplinary approach.
Exactly.
The other thing, of course, is the continuity care afterwards. What do we do for that?
I think we do that really well because our units are so close, and the same therapists follow the patients throughout, but the same doctors as well. So from the standpoint of being inpatient, we do try to transition them to our partial program and intensive outpatient programs, and then ultimately back to the home environment.
The beauty of that is this program is so unique in that if you were to really follow a patient, the patient then doesn't have to retell their story. They can actually stay with the same team, work on the same coping skills.
Develop that trust.
Exactly.
Continue that trust.
Learn what that's all about, what a relationship really can offer.
Which again, since we're talking about the fact that eating disorders usually are part of a mental illness or depression or anxiety, to have to change therapists, to change dietitians, to change nursing, would probably push the person backwards, and possibly someone who had been an inpatient and he had transferred to an outpatient possibly could go backwards.
Very much. You could get re-traumatized. You might just get frustrated with having to keep telling the story.
We already talked about this. Why do people keep asking me?
So overall, between the three of you, what should the audience take away from this?
Well, I would say if they have any concerns or questions, to please call our Behavioral Health Access Center number, which you gave, the 800 number, gives a lot of information. Even if they suspect someone is having a problem, that would be the first step. And
from your point of view?
I would just stress that if you feel someone you know has an eating disorder, or if you have an eating disorder, you know, don't delay in getting treatment, because you know, prompt aggressive treatment is important.
And as a therapist?
You don't have to live this way. There's plenty of help, there's plenty of support, and you can recover.
And the fact is that Robert Wood Johnson University Hospital Somerset has this eating disorder program that's convenient right in the background. You don't have to travel across the river, across the country to find this type of multidisciplinary approach. I've got it right here. And I've got people who I can actually talk to as a primary care physician, continuing the continuity of care that I have with my patient.
Correct.
Thank you all of you for coming to the program. This concludes our episode of Robert Wood Johnson University Hospital's Health Talk. Please remember that the opinions expressed here by our medical experts are not a substitute for medical advice from your own physician. If you need a physician, please call our physician referral line at 1-800-443-4605. For more information about the eating disorder program at Robert Wood Johnson University Hospital at Somerset, please visit www.rwjuh.edu or call 1-800-914-9444. Thank you all for being part of this show.